clinical ear care specialist. As an audiologist, my main duties are involved in the diagnosis, treatment and rehabilitation of people suffering from hearing loss and balance disorders. And as a clinical ear care specialist, I specialise in the removal of impacted earwax, foreign bodies, infected debris and discharge. This client attended a couple of weeks ago, and you'll see straight away, this is her left ear. She had a large furuncle. Furuncle is almost an umbrella term for a swelling almost. So it could be a boil, it could be a blood-filled pimple or a pimple full of pus and discharge. It could be a swelling there due to infection. And it's right at the entrance of your ear. And when I asked her about this pimple or furuncle that she had, she explained that she has had it investigated previously, and she's also got a smaller one in the right ear, which we'll see a bit later on. But the doctors feel as though it's just a birthmark, so a skin tag from birth. She did mention that they have offered to excise that because it may be a contributing factor as to her wax buildup. So as the wax is trying to naturally migrate out of the ear, this furuncle or pimple is obstructing the pathway, the natural migration pathway of the wax, causing wax to then build up behind it. So I started off with a Zollner suction probe. Wax is slightly mushy, so I then went in with a Jobson horn. I've removed a bit from the entrance, so the lateral wax. I then instilled some olive oil drops, and you can see it's a bit of a. I'm just pushing this furuncle, this pimple out of the way, almost to get to allow the instrument to be inserted and get a satisfactory view. So that pimple will be making itself present during the video. You can see it there. It's just bouncing back up at the bottom of the screen. It did make the procedure slightly more tricky just because it's slightly in the way and you have less manoeuvrability with the Zollner suction probe. There's a bit of skin adhesion there, so I'm just trying to get a suction grip at the base of the ear canal where the wax is adhered to the base of the ear canal with some skin. So skin, keratin in the ear. It's almost like a double-sided sticky tape. One side sticks to the canal wall, the other side sticks to the wax. So quite often if you want to try and loosen this keratin off the canal wall, peel it off. Sometimes, however, if you can get onto the wax itself and detach the wax from the keratin, so the keratin's still in the ear, but you're removing the wax, you're peeling that off the keratin in essence. So there's two ways of doing it. Generally speaking, removing the keratin alongside the wax is the best way. So you can see that pimple's resurfacing there, and the wax is slightly mushy, which just makes it a bit difficult. You don't get always an adequate suction grip, hence why I put some olive oil before. And you can see that skin there at the base, it's really stuck to the canal wall, and you can see the glossiness just where I'm suctioning now. You can see that's all keratin that the suction probe is on, and we're just trying to peel this, and it's a lot more evident there. The skin is almost wrapped around the plug of wax, it's encapsulated itself. So the idea is you want to gently loosen this skin off the canal wall, so almost kind of retract it all the way around, and you generally do that by using little wriggle motions like I'm just doing there. And you could describe the keratin exactly like some sticky tapes or some sellotape. It really is adhered, in most cases anyway, it really is adhered to the canal wall. So I've got a large piece of wax coming out here. You can see all that skin coating here at the base. So all the lateral wax has been removed, just trying to navigate into the ear, trying to get past that ear pimple near the entrance. You can see some skin adhesions there still, and a big plug of wax, really medial, so this is right up against the eardrum. I did encourage the patient to attend more regularly, and they are quite prone to wax buildup, not only in this ear but also the right side, which you'll see the procedure after we complete this one. So I've got a suction grip here, and because of the skin adhesions, I'm just wriggling the wax in circular motions, just trying to tease the skin off the canal wall. In most people's ears, and especially in this patient's ears, as we go further into the ear canal, there is you get two bends in the ear. You get the first bend, which is probably half a centimetre into the ear canal, then you get a second bend, and that is probably between 1 centimetre and 1.5 centimetres into the ear canal, and around half a centimetre to a centimetre away from the eardrum further in, we get a region of the ear canal called the isthmus, where there's a narrowing, and then beyond that narrowing the ear canal protrudes outwards, and this wax is lodged beyond the isthmus, so it's really medial, it's up against the eardrum, and we're trying to wriggle this large piece of wax through this narrow aperture, which is always difficult when you work deep in the ear canal because of that. And also, if you've been watching my videos, I do try and explain the ear canal anatomy anyway in most videos. So the ear canal, it can be split up in thirds. The outer third is where the wax is generally secreted, so all the ceruminous glands and sebaceous glands that secrete wax. Also in the outer third of the ear canal, you've got all the hair follicles. That's where you get the cilia. You notice at the entrance there is some hairs there, but past the first third, past the first centimetre, it's very rare that you get hairs growing on the ear canal. And when you're at that region, it means that you're on the bony part. So the outer third is also made up of cartilage and some fatty tissues, so it is quite malleable. If you make contact with it, generally you don't really feel much. You can just, it's the same cartilage as your external ear, the pinna. So if you just pull your pinna around, or the tragus, which is the little flap, or the lobule, which is the bit hanging at the bottom of your pinna, that's quite malleable. But the inner 2/3, it's hard bone, so it's very sensitive. There's no fatty tissue there, and there's a very thin layer of skin measuring almost 0.1 millimeters thick, whereas the outer third, the skin, the thickness is about 1 millimeter, so there's a tenth of a difference there. You can see we're making some headway here, so I've managed to slowly just bring this wax forwards. Remember, the patient is awake, there's no local anaesthetic, no general anaesthetic, so whenever you're working in someone's ear, you have to be very delicate, very careful. We're not trying to go for speed. Is not of the essence in when you do wax removal. The main, at least mine anyway, my main prerogative is to make sure the patient is completely relaxed and comfortable throughout the procedure. And if that means I'll take a bit longer, by all means. I'm sure any patient, if you're watching and you want earwax being removed, you want your clinician to be considering your own welfare and levels of pain and discomfort. So this plug of wax is quite a large one, and we're slowly bringing it forwards, and you now can see the hairs. It means that we brought this wax from very deep within the ear canal to the cartilage portion, which is near the entrance, and that's where all the hair follicles are. And that pimple, it's obviously definitely not camera shy. It always wants to rear its ugly head, and there we are. Now this is another conundrum. So the entrance of the ear canal is obviously very narrowed because of this pimple. We're now having to somehow bring this wax completely out the ear canal with that pimple there. It's not one of those pimples where you can pop. I know there's a lot of pimple popaholics who watch Dr. Pimple Popper, Dr. Sandra Lee. We're not going to pop this pimple. If you're going to have this removed, you have to have it excised, so it's under local or general anaesthetic, and the patient was offered it, but they were reluctant to have it done. Sometimes some furuncles, they're full of pus and infection, and when you're removing the wax, you do inadvertently pop it. You've probably seen a few of my videos, if you look through my archive, through my playlist, that there is a few there that in the process of removing discharge, infection, wax, the pimple just bursts open, there's blood pouring everywhere. The patient doesn't feel any pain whatsoever. We just mop that up. We ensure the patient keeps their ear clear of water, and we should all be doing that, guys, so try and avoid water in your ear. Water's bad. Water can lead to ear infections, obviously, and if you've had a pimple that's been popped or burst in the ear, the last thing you want is water in there. So yeah, do make an effort to avoid water entering your ears. So if you're just washing your face or you're standing under the shower head, that's generally fine. The falls and creases of the external ear themselves help repel water from entering the ear. But don't purposely get the shower head in your ear, and obviously when you're having a bath, if you do have a bath, or if you're going swimming, try to avoid submerging your head under the water. Just see there a little bit of wax, very close to the eardrum, in the region called the annulus, so that's the bottom part, very deep. So finish with the left ear. The right side, before I even started the procedure, just put some olive oil wax drops just to soften it. Yeah, so going back to watering your ears, so there's several things that you can do if you're an avid swimmer, or you really enjoy getting your head underwater whilst bathing. You can get some custom swim molds made, so it involves an audiologist taking a cast and impression of your ear canal, and from that we manufacture a silicone-based hypoallergenic mold, and you pop that in your ear. It fits like a jigsaw piece, and it helps stop water entering the ear. Just going back to the procedure, there's a little pimple you can see there just on the right hand side. It's very small in comparison to the left, but just wanted to highlight that for you. Just in view on the right side, as we get this wax plug out, you can just see it on the right hand side. Other things that you can do to avoid water entering your ears, simple things at home. You can get a ball of cotton wool, lubricate it with some Vaseline, and just insert it at the entrance of the ear canal. You don't obviously want to put it too far in, because you do need to be able to get it out. And you can also get some foam swim plugs or some silicone dome-shaped swim plugs from the chemist or the pharmacy, or even from the supermarket now. So got the lateral plug of wax out of this patient's right ear, so just some wax further in the ear. There's a bit of wax that was stuck to the posterior canal wall, so the back part of the ear canal, with some keratin. You can see that keratin, it's as I'm wriggling it, you can see that keratin just loosening itself from the canal wall. You can see some hairs there, so that means the endoscope tips. You can see the endoscope is not even going that very far in the ear. The eye clearscope, the distal end is the bit that goes in, which has the lens. It's just positioned at the entrance of the ear canal, just where the hairs are, and this wax is obviously a lot further in your ear, and that's why endoscopic earwax removal is so great. The endoscope provides such a magnificent field of view. You can encapsulate the whole ear canal and eardrum, obviously if the wax is not there, in one view. Other techniques, other visualization techniques, so head loops, or microscope. So a microscope provides with fantastic magnification, up to 20-30 times, but the view is very narrowed, so you don't always know whereabouts in the ear canal you are. Also, when you're removing wax, it's very ideal that you can see the whole ear canal, so you can see how you're manipulating the wax. So there might be regions of the ear canal that you need to work on, loosen this bit, loosen that bit, and with an endoscope we've got all that in view. With a microscope or head loops, you use a speculum, so it's like a cone shaped piece of plastic that we insert into the ear first. That immediately narrows the view. It's more difficult navigating around the ear, and you're having to constantly move the patient's head or move your speculum, move your position. So this plug's almost coming out. Sometimes so at the moment the endoscope's not even in the ear. The endoscope, I'm holding it in my left hand. It's completely freestyle, so there's no support there. So sometimes people say, oh, it's a bit shaky. Well, yeah, I've got my right hand with the Zollner suction probe. I'm really wriggling this wax out, and I don't have a tripod. We don't use tripods to keep the endoscope steady. So when we're removing wax further in the ear, as the endoscope goes into the ear canal, there's a bit of support there, so it kind of doesn't move around. But at the moment, I'm just holding this freehand in my left hand, so naturally there's no grip when the patient's moving their head and I'm wriggling with my right hand. It's going to move a bit. It's not avoidable. You can't avoid that. So I hope that answers some questions, or that people, well, I don't think they ask questions, it's more of a negative comment they make, but I hope that makes you understand why sometimes the camera is not completely still, especially when the camera's, as I said, it's not being supported by anything. And there's a huge piece of wax there, Just going back into the ear, there's the tympanic membrane, healthy, intact, just some surface wet wax near the entrance. We could technically leave that because it's not causing any problems. You can see just there a bit of soreness, so the patient has been itching her ears a bit. So I've asked her to use some hydrocortisone cream, steroid-based cream over the counter. They're all the remnants from the ears, a couple of 3 still images, and there's a close-up coming up in a moment. I hope you enjoyed that video, guys. If this is the first time you're watching one of my videos on YouTube, please do subscribe to the channel, like, comment, share, select the bell icon so you'll get notified as and when I upload new videos. And similarly, if you're watching on Facebook for the first time, please like, follow the page, like the video, share the video, leave a comment. I hope you're all having a good weekend.